So I think without further ado, I've introduced myself. I'll start with the first talk, and I've been asked to talk about the true course of Lyme disease in the UK, which is an interesting topic because it's become a fashionable disease and a cause for a lot of controversy. So I want to try and cover that in the session today. Now, this is what we normally think about in terms of the areas where you might acquire Lyme disease, the sort of rural idyll of southern England surrounded by, populated by deer, where you might pick up a tick that might transmit a Borrelia infection. It's not just the New Forest, of course. The epidemiology of Borrelia occurs throughout Western Europe and Eastern Europe in varying degrees. But the disease itself of Lyme disease has been sort of divided recently by this rather unpleasant proboscis of a tick into two camps. Which I think is a great shame. There's a parallel universe of Lyme disease that has developed across the world. It's not just in Europe. In fact, it started in the US, and this parallel universe of Lyme disease has passed across the world to virtually every continent. And I'll explain what is going on there, because I think most of us in this room will be in the camp where, the sort of scientific camp, rigorously scientific camp, which regards Lyme disease and the left-hand column, that a disease that occurs focally, that's transmitted by infected ticks, that presents with objective clinical findings and requires a laboratory test to confirm the diagnosis. And when that diagnosis has been confirmed, patients tend to respond pretty rapidly to short courses of appropriate antibiotics. But there is another view, the parallel universe view of Lyme disease, which is that this disease is insidious and ubiquitous. It occurs everywhere. It may not even be transmitted by ticks. There's some views that it could be transmitted by other arthropods, and indeed possibly even person to person or vertically from mother to baby. It presents with non-specific symptoms alone and can only be diagnosed on clinical judgment. Laboratory tests are often not positive, not confirmatory. That the disease may require months or years of antibiotics to cure and can only be diagnosed and managed by Lyme literate doctors. So this is the parallel universe of Lyme disease, which is a difficult problem to control. There are lots of patient advocacy groups across the world, some of which are frankly quite aggressive in their approach to their supporters' illness. This is, in my view, the most responsible patient advocacy group. And I don't know whether there is anybody in the audience from Lyme Disease Action, but it would be helpful. Is anybody here from Lyme Disease Action? Because I think they're a very useful patient support group. And if you have patients who have chronic Lyme, seronegative Lyme, I would recommend that you put them in touch with Lyme Disease Action, because they are responsibly trying to support those patients who have these chronic symptoms and find some solution for them. But Lyme Disease Action believe that there's just this huge gulf between clinicians and patients in terms of the chronic disease, and that gulf may never be bridged, who knows, but we need to try and work on it. So there are these two syndromes: Lyme disease transmitted by Borrelia burgdorferi and chronic well, I'm trying to develop a new acronym, a new name for the chronic illness, because it is a totally different disease from true Lyme disease. And I think we should call it chronic arthropod-borne neuropathy, and I'll come on to develop that theme as we go through the talk. We all know what causes Lyme disease. It's Borrelia burgdorferi, the different strains, and the antigenic, there's antigenic variations, geographical antigenic variations, based on where you acquire your Borrelia. So in the States, there's Borrelia burgdorferi sensu latu, and in Europe, there's different strains of Borrelia that have different antigenic structure, and and that's probably responsible for the different clinical presentations, whether it's just dermatological or whether there's neuroborreliosis. more work needs to be done on that. And as a slight aside, many of the chronic Lyme believers, as I've mentioned, believe that Lyme disease is ubiquitous across the planet, but certainly across North America. But actually, if you look at the confirmed cases from CDC in North America, and each one of those dots is a serologically confirmed case, they are mostly along the eastern seaboard of the United States, which is, of course, where the first European colonizers arrived. So I think that fits in with it being a European disease that was brought over to North America by Europeans. If the disease was much older in the North American continent, you would have expected it to have come with the early colonizers across the Bering Straits and for it to be much more widespread throughout the continent. This view of a European disease, I think, is supported by molecular phylogeny, which you can see in the bottom right, which shows that US strains are genomically separate as a population from the European strains and diverged at a point sometime in the past, but I suspect brought over by a chap like this. So that's just an interesting observation. Borrelia are complex organisms. They're complex spirochetes with a variety of surface proteins, which is why the serology is also so complicated. When we send back reports from Ripple, from the Rare and Imported Pathogens Laboratory, I think the reports are actually quite confusing for those of you who receive them and have to try and interpret them. They currently report all the bands in the immunoblot, which has come about because of these patient advocacy groups who insist on having every bit of detail in terms of their serology. They want to know which bands they have responded to. But I think it's not terribly helpful for those of you trying to treat patients and trying to interpret the results. So I want over the next few months to try and simplify that reporting process. But the difficulty is that these spirochetes do change their antigenic structure fairly frequently. So when they're in the tick, they express certain proteins which are designed to allow the spirochete to attach to tick tissues. But as the organism passes from the tick into the mammalian host, then those expressed proteins do change. This one down the bottom, which is the main attaching protein, goes from OPS-A to OPS-C, and that's one of the earliest expressed proteins in the mammalian host, which elicits an early antibody response. So antibodies develop against certain spirochete proteins early on in the disease, and these evolve and change as the disease progresses. So you will not only get a change in the IgM response, but also a change over time in the different bands in the IgG immunoblot. The organism, of course, multiplies locally at the site of the bite, and then can disseminate through blood and lymphatic tissue, classically in the UK, unlike in the States, causes neuroborreliosis. In North America, it's much more common to have arthritis. Arthralgia is not uncommon in the UK, but frank arthritis is, to be honest, pretty rare with European strains. And then myocarditis is pretty rare. And chronic skin conditions like acrodermatitis chronicum are really pretty unusual because most patients in Europe are treated reasonably early on, so they never develop these chronic changes. There's a common antibody to the VLSE protein, which appears early and often remains as an IgG, as one of the bands in the immunoblot for many years afterwards. But the VLSE protein has a conserved region here in orange, but the rest of the protein is very variable. And this sort of allows the organism, in a sense, to evade the immune system. But, of course, this conserved region is always present, and that represents the main protein for quite a few of the ELISA tests, certainly the C6 ELISA test that Ripple use as the main screening antibody. But the protein itself may evolve and develop as time goes on. So at the Rare and Imported Pathogens Lab, which is the national reference laboratory for Lyme disease, they took this over from Southampton in June 2012, and they currently use a two-tiered testing system. They use a basic C6 ELISA, which actually is a very sensitive test. If anything, it is too sensitive. We don't really use the immunoblots, we don't really use the technique of immunoblots much for diagnosing other infections. So you might ask, well, why are we using it for Lyme disease? Well, the real purpose of the immunoblot in Lyme diagnosis is to rule out the false positive C6s. Because it is such a test, it has very high sensitivity, but there are a number of false positives, which the IgM immunoblot helps to resolve. Ripple are now using a printed blot system, ViraStripe, which is machine readable, and so it's read by a densitometer and has less background interference. So I think it helps with the interpretation of that. This is just the Lyme C6 assay, and these are the printed, well, in this case on the screen, but comparing the control blot here with a test sample with all the antigens laid out on the blot and readily readable by an automated densitometer. And we use a printed blot now because, for the reasons I was saying, that it's much easier to read than a standard blot, which has lots of background interference and variable band density. So you only have the bands, the antibody bands that you want. And so this is the sort of result that's being sent out at the moment from Ripple, which I appreciate is pretty confusing. But as I explained, the reason they're doing this is because of the patient advocacy group demand that every aspect of the test is reported. But I think we need in Ripple to simplify that reporting system so that it makes it easier for not only microbiologists and infection doctors, but also for patients and GPs to understand as well. But this lists most of the proteins that are on those bands.